From the American Academy of Pediatrics.
Participation in sports can have tremendous physical and mental health benefits for kids.
The key is finding a balance between training and recovery.
And so we want to know, are they playing on more than one team at a time or more than one sport at a time? How many days a week are they doing each one?
Plus, new research shows the effectiveness of mentor trios in family-centered rounds.
The neat thing about the mentor trio is that there is a parent, a nurse, and a physician who work together as equal partners in coaching each site.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about preventing overuse injuries and burnout in youth sports.
David, I haven't asked, but since your youngest son went to college, has he been playing soccer?
He hasn't said anything about it, although initially he thought he might enjoy an intramural game. I'm afraid he is still burned out from travel ball when he was younger. You know, he was all about soccer until one day he just wasn't.
That makes me kind of sad and makes me feel like maybe I should stop joking about pushing my left-handed son into baseball so he could be a pitcher, even if we're concerned about his college education.
You know, it's crazy how competitive sports are for kids these days. And I can't say I missed all the travel and expense and practice time, but I did miss him being so excited about what he was doing. He did enjoy being a ref after that, especially the pay.
It's time we learn more about how early is too early and how much is too much when it comes to youth sports. The AAP recently released a clinical report, Overuse Injuries, Overtraining, and Burnout in Young Athletes. And today we have both authors with us, Dr. Joel Brenner and Dr. Andrew Watson.
Dr. Brenner practices sports medicine at the Children's Hospital of the King's Daughters and Children's Specialty Group in Norfolk, Virginia, and is a professor of pediatrics at Eastern Virginia Medical School. He's a member and past chair of the American Academy of Pediatrics Council on Sports Medicine and Fitness.
Dr. Watson also is a member of the American Academy of Pediatrics Council on Sports Medicine and Fitness. He is a pediatric sports medicine specialist at the University of Wisconsin, where he provides medical coverage for the Badgers men's hockey team, the men's and women's swim team, the men's golf team, and the softball team. Drew and Joel, welcome to the show.
Thanks for having us.
Great to be here with you guys.
Well, I am thrilled to talk with you both. In my practice, I'm always encouraging kids to be active, and organized youth sports seems like an obvious way for them to do that. But given the trends in youth sports today, can they be as much of a problem as a solution to inactivity? Joel, what are your thoughts?
So I think organized sports play a vital role in physical activity. There's a lot more positive than there is negative with it. And so we do want to encourage kids to be physically active through both organized sports, if that's what they want to do, and free play, along with other activities. We just need to really find the balance and balance out their volume of training with their rest and recovery.
And Drew, the report starts by covering overuse injuries. How common are those injuries in young athletes, and how do they typically occur?
Yeah, I think first I would just briefly echo what Joel said, where I think the context here is really that we recognize the extraordinary value of youth sports when they're done right. I mean, the reason that's the first sentence of the entire report is really that they do potentially have really big physical and mental health benefits for children when they're done properly. Overuse injuries are an issue, and I think on some level, in certain cases, we are seeing more of these recently than maybe we did in the past. Broadly speaking, they're just an accumulation of the sort of microtrauma you can get from repetitive activity if you don't have enough recovery in between those bouts of exercise. And we think that young athletes may be at a little bit more risk than older athletes because bones are maturing, mechanics are changing as they grow, and this potentially lends itself to these sorts of injuries if they don't have that right balance of stress and recovery.
I know we've heard that kids who spend all their time on one sport might be at higher risk for these overuse injuries. Drew, are there other risk factors we should also be aware of?
Yeah, I think it's quite individual. I think there are a lot of things that could potentially lend themselves to this. Certainly, we see more of it when athletes are doing really kind of homogeneous biomechanical repetition. So if you're throwing a baseball over and over and over and over and over, that's a very similar load on structures, particularly in the elbow, that we see a lot of. When athletes are doing more heterogeneous movements, like your son is a soccer player, soccer is a very kind of diverse set of movement patterns. And I think it's less likely, or it may take a different set of circumstances for someone to develop an overuse injury in soccer. They certainly happen, but they're going to be very different than what you might see in a young thrower. Fitness level certainly seems to lend itself. So kids that are a little more acclimated to the sort of stresses they're going to be seeing, maybe at less risk than kids who go from kind of 0 to 100 miles an hour at the start of a season. Physical maturity certainly plays a role. As we mentioned, bones develop, soft tissue structures mature, mechanics change. And so really, I think there are a lot of individual factors that potentially lend themselves to this that we as pediatricians and sports medicine providers are trying to get to the bottom of whenever we see an athlete that we think is at risk.
Drew, there are two terms in this report that to me seem a little confusing, and I'm hoping you could help me clarify. There's overreaching and overtraining. What's the difference?
Yeah, that's a great question. So as we all appreciate, if we go out or an athlete goes out and undergoes a training stress, right, they participate in a practice, they'll have a period of intervening recovery before they train again. If we combine those things properly, if we balance the stress and the recovery adequately, they get all of the physiologic adaptations that we expect from sports training. If they have insufficient recovery for the amount of stress they experience, over time, they can actually begin to develop a decrease in performance. That initial phase is called non-functional overreaching. If that goes on for a long enough period of weeks or even months, they can ultimately transition into overtraining, which is defined as this otherwise unexplained decrease in performance that gets accompanied by things like sleep issues, mood problems, other cardiovascular, neurologic, and even endocrinologic dysfunction. So they're sort of along a spectrum. And unfortunately, we don't have a tried and true diagnostic tool for them. They really are diagnoses of exclusion. And for that reason, often come at the expense of lab tests or evaluations to rule other things out, but ultimately are a function of that imbalance of stress and recovery. And the only solution to both is altering that balance so that we reduce their training load, we prioritize things like sleep, nutrition, hydration, stress reduction that will increase their intervening recovery. And for non-functional overreaching, that might get somebody back to where they were within a couple of weeks, but in overtraining, depending on how long it's been going on, it can be months of training load reduction to get them back to where they were.
So I have a family in the clinic and they're really involved in a sport. Joel, what can I do to help them protect their kids from overuse injuries?
Great question. So first and foremost, I would start by asking the athlete, one, if they're still having fun and enjoying the sport that they're doing, and find out what their goals are. Do they want to go and play in high school, in college? Do they have aspirations for elite level? And looking at also their training volume. And so we want to know, are they playing on more than one team at a time or more than one sport at a time? How many days a week are they doing each one? Are they, doing 2 practices on the same day? And then how much time off they have, not only during the week, but also throughout the past 12 months. So those are really key questions, because what we know and what we put out in the statement is that recommendation is to have at least 1 to 2 days off per week from a specific sport, and at least 2, if not 3 months off from that specific sport, broken up in month increments here and there. And then again, during that time off, though, throughout the year, we're not recommending that kids remain physically inactive. So we still want them to be active and meet the physical activity guidelines, but they can be doing other activities, whether it's cross training, another sport, or another activity such as drama club, or just going out hiking with the family and doing things that you can't do if you're doing a sport nonstop year round.
So this report also talks about burnout, which is a word that I think we hear a lot as pediatricians in practice, referring to our own demanding profession. But it's also a thing I think I've seen in my own family, as we talked about at the beginning. How should we identify when a young athlete is at risk of getting burned out as opposed to overreaching or overtraining? Joel?
So in terms of burnout, this is definitely something that we see in young athletes that, 15, 20 years ago, we didn't think about as much. We hear about it, as you said, in physicians, but in young athletes, the things that we need to be on the alert for are kids who are just no longer having fun doing their sport. They're just physically and emotionally exhausted, and they just don't want to participate anymore. And those are things that can be preventable if we are, when they're in the office or from a coach or a parent, if we're communicating and again, asking the important questions. Are you still having fun? Do you want to continue with the sport? Do you want to do a different sport? Are you taking enough time off from that too? And burnout is different from overtraining, where in overtraining, they're training, but their performance decreases, but they can also get some other symptoms such as sleep disturbance, mood disorders, fatigue. So we need to be on the lookout for both of them.
And Drew, just like with overuse or overtraining, as Joel just mentioned, are there some athletes that are at higher risk for burnout? Is it a population that's similar to those who are at risk for overuse or overtraining?
Yeah, I think Joel really kind of nailed it. And I end up spending a lot of my time parroting his opinions because he's such an expert in some of these areas. But I think the motivation question, I think, is really the key one. I think burnout and overtraining can have a lot of similar symptoms to me, but it sort of boils down to why are they there and how are they sort of interacting with their sport? And athletes who are still very motivated to participate, but are really enjoying their sport, but nonetheless see this decreased performance and maybe these associated issues with sleep and mood and fatigue, those are the ones where once we exclude other things, we think that perhaps they're suffering from overtraining. I do think this tends to happen more in athletes in certain populations. So endurance athletes are sort of notorious for being at a higher risk for this. It does seem like athletes with a lot of kind of extrinsic motivation are potentially at an increased risk because they may be subjecting themselves to the sort of training loads in excess of their ability to recover for reasons that aren't necessarily their own intrinsic goals. But I think the whole sort of diagnostic process, and for us interacting with athletes and families, really sort of initially boils down to what their motivation is. And to me, differentiating burnout from overtraining is really identifying the athlete that's still very interested and motivated in their sport, but struggling to perform, versus the athlete that has really started to devalue their sport and become less and less interested in it, in addition with some of that exhaustion, which makes me think more about burnout from the outset.
So, Drew, you and Joel emphasized this earlier, that we really want our patients as pediatricians to be active and healthy, and we're excited when they want to incorporate sports into their lives. But what do we need to be counseling our families on the front end so that they are less likely to run into some of these problems that we've just been talking about?
Yeah, I think both of our opinions and the evidence that I like to think those are built on are really talking about what it is that motivates athletes to play. I think children are terrific at guiding us to the things that are good for them over the long term, whether that's they learn about a sport from a friend or they learn about it from PE and they want to participate in it outside of school. Allowing those sort of conversations to generate organically in families rather than pushing activities onto kids is a great way to make sure that when they start out, they're doing it for the right reasons. And that ultimately we're trying to facilitate activities that are enjoyable and are in the service of things like physical activity, fun, social engagement, all of the things that we value from sports rather than some extrinsic goal that gets sort of thrust on them. So early on, I think it's allowing children to explore as many different activities as they can, identifying the ones that really kind of resonate with them, whether for social reasons or skill acquisition reasons, and then just facilitating that as parents and clinicians to allow them to identify the activities they really enjoy, sample enough of them to make sure that that choice is informed, and then allowing them to really continue to set and seek goals for themselves as they get older. I think one of the big issues that sort of came and went within the last 10 or 20 years is we really got rid of a lot of physical activity in schools where it is accessible to everybody. And the expansion and proper funding and really deliberate training of physical education teachers would go a long way to improving sports sampling, improving movement literacy, allowing kids to experience a whole host of different sports so that if and when they come to a point where they want to do something outside of school through a club or a community organization, they already have this base of experience and enough breadth of experience that they can identify activities they're really interested in. When we kind of removed a lot of that, it becomes a very complicated problem for parents to figure out how to help their kids sample different sports while paying for them, not overscheduling them, and navigating all the confusion that exists kind of out in the youth sports world. I think we really do need to be thinking about how to fund and expand opportunities within physical education really early for children to develop all of that movement literacy and sports sampling we know is so beneficial.
So much great information, and we want our listeners to read the clinical report. But before we let you go, could we get some last takeaways? Joel, let's start with you.
The key is communicating with the families and really asking directly to the young athlete and getting answers from them directly, and then helping and counseling the parents too. But really, I want to emphasize the point that Drew makes. We need to figure out what the intrinsic motivation is for the young athlete, and also find out what are the extrinsic motivators or extrinsic stressors, so that we can then try to alleviate them through counseling coaches, counseling parents, so that these kids can remain physically active, not only as young people, but into adulthood, and to help them be both physically and emotionally well balanced and have wellness throughout the rest of their lives.
And Drew, any last thoughts?
Yeah, I think I might just say again that I tend to be a little heavy-handed about this, but I think organized sports are a potentially extraordinary public health intervention. And while we do spend a lot of time trying to identify the potential negative outcomes of organized sports in certain contexts, our main role should be to try to facilitate access to physical activity in sports for all children. The numbers of children that we see discontinue participation at young ages lends itself directly to the huge proportion of children that don't meet the recommended physical activity guidelines. And so as pediatricians, as parents, as community members, the roles that we can play in overcoming the barriers to access to organized sports that a lot of children experience is really one of the best ways that I think we can intervene to help physical and mental health for kids in the U.S.
The other thing that I think us as advocates for young people, and some that Drew and I have been trying to do over many years, along with our colleagues, is trying to change youth sports culture. Because with the professionalization with travel leagues, it really stems down from changing the culture. We can, in the office, affect one person at a time, one family at a time, but we really need help from all healthcare providers to change the culture, to help communicating with the national governing bodies, with the NCAA and everybody else, so that we can make a long-term difference. And like Drew said, too, there's a lot of people who cannot participate in organized sports because they can't afford to join travel leagues. They can't afford the equipment, the travel. So we need to find ways to make this accessible for everybody, no matter where they are and no matter what their personal situation is.
Well, those are some fantastic thoughts, Drs. Joel Brenner and Drew Watson. I think our listeners are ready to take that ball and run with it. Thank you for talking with us today.
Again, thanks for having us.
Yeah, thank you, guys.
To read the clinical report, Overuse, Injuries, Overtraining, and Burnout in Young Athletes, go to aap.org/podcast.
Coming up, we'll look at using mentor trios to encourage family-centered rounds.
Joanna, I'm curious, as an attending at an academic children's hospital who sees hugely complicated patients, how much do you think about how you round?
Wow. I mean, rounds occupy a lot of my time and energy every day I'm on service, David. So I think a lot about them. I think about how I'm timing rounds, how engaged my trainees are, if it's a good time to teach, if I should wait till after rounds, getting families to listen to rounds. And some days rounds last from around 8 in the morning to around 1 o'clock in the afternoon. And that could be about half my workday just rounding.
Oh, I completely believe that. Depending on which institution I'm at, my rounds are usually a lot simpler than that, but I've still seen a huge change since I trained, when we presented at length outside the room and then walked in, peeked at the kid, chatted with the family, and moved on. Still, I wonder if I could be doing it better, like if I had a mentor or something.
Oh, mentorship is so key to progress in medicine. And today on the podcast, we have two mentors to talk about rounds, David. And they put a lot of thought and energy into how every member of the team and family can get the most out of it.
You mean they've been around?
Ching. Thanks for that, David. They have. So let's welcome them here today. We have Dr. Alisa Khan and Dr. Shilpa Patel, among the authors of a new paper in pediatrics implementing a family-centered rounds intervention using novel mentor trios. Dr. Khan is a pediatric hospitalist at Boston Children's Hospital and assistant professor of pediatrics at Harvard Medical School, who studies interventions to improve family engagement in hospital communication and safety.
Dr. Patel is Senior Vice President and the Chief Quality Officer for Hawaii Pacific Health and a pediatric hospitalist at Kapiolani Medical Center for Women and Children. She's also Professor of Pediatrics at the University of Hawaii John A. Burns School of Medicine. Doctors, welcome.
Thank you for having us, David and Joanna.
Thank you for having us.
So the two of you have put a lot of thought into how we round at the hospital. Can you tell us what makes rounds patient and family centered and why it's important? Let's start with you, Alisa.
Sure. What makes rounds patient and family centered is really effectively partnering with patients and families in all aspects of decision making. So actually having the conversation at the bedside and in a way that patients and families can understand and that meets their concerns and questions and goals.
And why is that important to have these families so involved?
Families are experts on their children and often notice things more quickly than members of the medical team. And they are essential to being able to move forward the plan and to provide information that helps make diagnoses and makes effective plans. And ultimately, it's about their children. And so they have a right to be involved and to share what matters to them.
I would just add that because the family also is integrally involved with taking care of the patient in the home setting, their input in making the plan after discharge is equally as important as plans during the hospital stay.
Dr. Patel, I know that in pediatrics, we certainly strive to meet the goals of the families we see, but I'm sure that places vary. How many services already use patient-centered family rounds?
Family-centered rounds are very common in pediatrics. We started doing them, I would say, in the early 80s or mid-80s, a different iteration for sure back then. There are other pediatric subspecialties that use family-centered rounds. One of the sites that was involved in our study was a pediatric neurology service. However, I am not personally aware of other services such as the adult hospitalists or other adult subspecialty services that use family-centered rounds, patient and family-centered rounds.
And what parts of the rounding process did you think could potentially be improved?
The part that is most challenging is to get everybody in the room and engaged at the same time for the duration of rounds. And part of the challenge of that is that we have different people in the rounding room that have different agendas. We have the third-year medical student, possibly a fourth-year medical student who's doing an acting internship or a sub-internship. We have the first-year pediatric resident and then, possibly a second or a third-year resident as well. And then, of course, the family. And we also have the nurse. And everybody has different goals of what they need to get out of that rounding encounter. So when we are able to understand the patient and family's goals, we can tailor the discussion that happens in the room to those goals and then deal with all the other stuff outside of the room.
Well, Shilpa, I'm glad you mentioned that, because one thing reading this study that I was taken with is its scope, because not only did you include 30 sites, at each site you had all those different groups you mentioned: parents, nurses, trainees, attendings, mentors. So Alisa, how did you manage to involve all of these people?
There were many steps in involving all of the people, and I think there was a lot of purposefulness to building relationships, building connections, and really emphasizing for each group why this is meaningful. And I think the reason it's meaningful may be different for a patient and family than for a nurse leader than for a frontline nurse. And so I think really being thoughtful about ensuring that we have everyone's voice at the table and really making a case for why this matters, not just because it's the right thing to do, but because this will make your job easier or your communication more effective or your child's care safer. And so I think there was a lot of building of connections and talking to folks at all different levels of the organization and the care team in order to mobilize people who represent each of those different groups.
And Dr. Khan, I'm curious about this mentoring trio. Who's in this trio and how do they mentor?
So the neat thing about the mentor trio is that there is a parent, a nurse, and a attending physician who work together as equal partners in coaching each site in implementing, in this case, patient and family-centered IPAS. But it's a model that in theory could be used to other improvement interventions. And so essentially, it involves the mentors meeting with each other in advance, either in real time or over email, asynchronously or synchronously, kind of dividing who's going to be talking about what piece. There may be a piece that addresses a question that's family specific as opposed to nurse specific when it comes to rounds. So really trying to build on people's expertise and lived experience so that they can bring that as they're coaching the site. And to give a practical example, one of the challenges that came up was, how do we get nurses to the bedside when they are busy administering medications, doing other tasks, and carrying multiple patients? And so that was a question that we did a lot of brainstorming with our nurse mentors as well as the nurse mentees to think through, hey, what can we do? And with our physicians saying, hey, would this be practical for you to call the nurse 2 patients ahead instead of 1 patient ahead? So it was really a collaborative sort of, we're equal partners, let's work together to make this project better.
And Dr. Patel, I was very impressed at the human power and engagement that this study required. In a realistic way, are these processes that lower resourced hospitals might be able to duplicate?
Absolutely. And I think that this particular dissemination and implementation study speaks to that. We had a variety of hospitals within our 21 sites that varied between community teaching hospitals to large academic hospitals, and no extra research nurse support, et cetera. So the attending hospitalists, as well as the nursing leadership and the patient and family advisory representatives, were able to mentor in a way, and through COVID, by the way, they were able to mentor the sites to implement and adhere to high fidelity throughout very challenging times.
And after implementing these changes, getting all the information for your study, what outcomes did you find? Did rounds change, Dr. Patel?
What we studied was that people were able to adhere to the framework that was outlined, the IPAS rounding framework. And the sites that were able to have high adherence to it over a sustained time, as well as have nursing involvement and engagement in rounds, had better sort of safety climate or culture of safety, as well as improved resident reported harms.
And Dr. Patel, I'm wondering how the teams responded to these interventions. Did they like them, and did they like them enough to keep doing them?
Well, that's always a challenge. Change is hard, and there's often resistance to change, especially in the beginning. Part of the process that we used was to use the sort of national mentor trios to help prepare the local teams. So there was a lot of support from the national study team to guide the local teams in preparing for rounds. One of the things that we did was to observe how rounds were occurring at baseline as compared to the IPASS patient and family-centered rounding structure. And we didn't give feedback after those observations, but it allowed us to kind of set the scene for the need for change. And that was engaging to the local teams.
And Dr. Khan, did the changes have lasting impact?
I think we're still trying to figure out if they have a lasting impact. There are parts of the changes that I think are easier to implement, for instance, starting with the family and providing a written summary of rounds. And then there are changes that are harder to implement, like, for instance, the read back piece, where I think sometimes we found that the read back where the family reads back in their own words what they take the plan to be. Sometimes that's something that doesn't stick as much. And so I think we're still figuring out the extent to which components are still sticking. But I will say from personal experience, the rounding at the bedside, family speaking first, and kind of having the family's goal set, I think are some pieces that really do stick and are really meaningful.
And speaking of meaningful work, this paper I think would be so meaningful to our listeners to go and read right now. And before they go do that, do you both have any last takeaways about the article for those listening in today? And let's start with you, Dr. Khan.
Something that I would love our listeners and readers to reflect on is the role of patient and family-centered rounds and health equity, and how they can be a vehicle to ensure that our communication is equitable to all patients and families, regardless of their background, the language they speak. And that's an area of future work and a passion of mine to really improve communication for all families. And so I think that is an area that's really important to be thoughtful of, to make sure that when we do these things, we are doing them in a way that reduces inequities and does not contribute to them. And so we want to make sure that we are rounding with families who benefit from interpreters and doing family-centered rounds in those instances too, not just those who speak English. And so that's something that I think is really important as a next step and something to be really thoughtful about. And we actually have a project that seeks to do just that. So if you could stay tuned for about 5 years, we'll tell you more about it then.
And Dr. Patel, any last thoughts?
I would say that the most important part about this paper is the what's in it for me. And by that, I mean the learners, the patients and families, the nurses, and we as the attendings benefit greatly from co-producing the day's plans and communicating clearly about that. Even though it might take more time up front, it saves so much cross-communication and closing the loop later in the day.
Well, Drs. Alisa Khan and Shilpa Patel, I want to thank you for communicating so clearly about this important paper. Thank you so much for joining us.
Thank you for having us.
Thank you for having us.
To read the article, Implementing a Family-Centered Rounds Intervention Using Novel Mentor Trios, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, my son Julian, my youngest, was just back from college, and I love learning these things that I would never know if the kids didn't come back and tell me this. So he's into music right now, and he's going to punk shows and in the mosh pit, okay? But there's a whole social contract in the mosh. There are ways to mosh. That's why they don't all end up in the ER. And he's telling me about the right way to mosh. And I don't know if you would imagine this about me, Joanna, but I've never been in a mosh pit. And
That's
now I guess I'm a
shocking,
little better
David.
prepared, you know?
Yeah, well, it's good that you got that info from your kiddo. I'll make my say about music as well. While I'm not excited for my kids to enter mosh pits, I did let them watch the halftime show with Usher.
Yeah.
And so now we're listening to a lot of Usher in the house. And I have to say, that is my say It's a great show. And now I'm getting my kids into music that I was into when I was younger. So it's
that
like
is
a little
the
bit of a
best.
fun blast from the past.
Oh, I love that. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss strategies for improving vaccine communication and uptake.
We'll talk to one of the authors of a new clinical report, Dr. Jesse Hackle. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.